Thank you very much, Case. And this is my last lecture before I leave, and I'm extremely grateful for inviting me for an incredibly impressive meeting, a fantastic place, huge hospitality, and this has almost been like a home from home. I've met so many people who worked in Dublin with us, who trained in Dublin, and thank you very much indeed, and it's been a great privilege to be here. My last talk today is esotropia, when to intervene. And this is, as you know, this is the sort of picture they come, large angle esotropia, and then it's the nomenclature is, it's not even though we call it congenital esotropia, probably the more correct term is early onset esotropia. And it has two variants of the Cianci syndrome, where there's a large angle with a phase turn, and it manifests late in nystagmus, worse in abduction, and then the nystagmus blocking syndrome, and sometimes you get a combination of both of those, and it's hard to distinguish each one of them. This is the great controversy that arises, and if you know Ken Wright used to be, and probably still is for all I know, an ophthalmologist down in California, and he operated on his son in the first 6 months of life. He did what I think was a surgical procedure. And he made the claim that these kids, if they were operated on early on in life, could get a high grade of stereoacuity after early surgery. And so then began the quest as to when one should do surgery in these children. The timing of surgery, obviously, there's early versus late surgery. Early surgery may be associated with what he described in his child, getting good binocular response. And if you do that early, that's what you get. And then there's the question of late surgery, because early surgery, first of all, it's difficult to go into a baby's eye and try and do surgery on muscles. And late surgery, on the other hand, if you wait, you get accurate measurements of the strabismus, which you don't do in early surgery. And you may be able to do a single surgical procedure, whereas you go into early surgery, you're probably into multiple procedures. And the view is, and the conventional view is that binocularity is not possible, and at best case scenario, you'll get gross binocular function in these children. And this is the child with cross fixation, which is commonplace. And so, obviously, the danger of early surgery is that you remove the cross fixation and you end up getting amblyopia. And then, obviously, it's just not the horizontal deviation. It's the DVD, dissociative vertical divergence, which usually appears later, inferior oblique overaction. And a lot of this vertical surgery only comes on later, and sometimes even after from 5 to 15 years of age. So if you're doing early surgery, you still have to do late surgery to correct these two other vertical deviations. And then there's the DVD, which can be unilateral or bilateral, and invariably follows on later in many of these children. There's the inferior oblique overaction, which is again quite commonplace in these later on as the age of 4 or 5 onwards, when it becomes manifest and which you're able to detect it better. One of the areas that many years ago I was in Peru, and at a meeting like this, and one of the doctors presented a whole series of children with infantile esotropia where she'd used Botox. And she got most incredible outcomes, like they were getting good binocular function. So when I came back to Dublin, I decided I'd use this because it's not too difficult. And so I did a number of children at 6 months onwards, up to a year. And I must say that I was never able to repeat her outcomes. These children, they went obviously divergent initially, then they came back in, straightened for a while, and then went back in again. And I repeated it a number of times twice, in fact, in many of them. But none of these children got any high grade of binocularity afterwards. And there's the two approaches to this, and you do it before 1 year. There's a transconjunctival, which I did. I opened the conjunctiva to identify the muscle. Or you can, if you can, do it by direct visualization. If you do it in transconjunctival, you've got to put them to sleep. Visualization may be able to do it with them sedated, although I think that might be difficult, and I've never tried it. So early intervention, the development of binocularity, greater number of surgeries over the life of the child. Small angle deviation, end up with a small angle deviation, which can be dangerous because you get this false sense of security, the parents do, and then they end up with amblyopia, and they lose the drive to alternate. And before 12 months, as I said, accurate measurements of the deviation is quite difficult, so there's a risk of overcorrection, undercorrection. On the other hand, there's the psychosocial functioning and the parent pressure to do something early on in life. The types of surgery, obviously the deviation is often larger for near, and so medial rectus recessions is often preferred. I mostly prefer recess, resect, and sometimes you have to do 3 muscles because these deviations are large. Outcome measures, obviously, the outcome measures are the stable binocular alignment within 10 prism diopters of straight, microtrophia and gross binocularity, and obviously the outcome measures are determined by the number of surgical procedures to reduce alignment. So if you operate on them late, you're going to do less surgical procedures, and then the risk of complications in early surgery, especially doing very early surgery, the risk of loss of the muscle and so on. And most importantly, in my view, with early surgery, you give a false sense of security. The child may not come back. They may have a small degree of strabismus, and they can be notorious for inducing amblyopia. Recently, Payment's Principle of Ophthalmology, they produced a second edition, which I've edited, the pediatric section. And this is, I think, a very good diagram from Ian March in Liverpool, and a treatment for early onset esotropia. And one thing that I should mention to you, clinical examination obviously confirms, but some of these children are significantly hyperopic and anisometropic. And don't forget that these children often need glasses as a first procedure or sometime during the course of the treatment that they're undergoing. So if they don't need glasses, he summarized it in 3 areas. Early surgery, operate before the age of 2, and that's one option. Late surgery is observe until they're about 4 or 5. They alternate well, so there's no question of amblyopia. Easy to get measurements. Sometimes the inferior obliques are already active at that time, maybe not the DVD. So you can do more than one. You can do more than one muscle and eliminate some of the surgical outcomes, repeat surgeries. And the other issue, I think, which I found, because there was one other person in Dublin who operated on these quite early, and many of them are coming back as older patients, amblyopic and with consecutive divergent squints in later life. And that, I think, is another big issue. And then the final thing is Botox. If you're going to do it, you do it before 12 months. As I said, you operate, you inject into both media recti. I did it transconjunctivally under anesthetic. I have not been able to reproduce any of the outcomes that that happened in Peru, and I think there's a few publications suggesting that. So, in summary, what do? I operate on these children late. I operate them by the age of 5. I no longer operate on them, certainly not do surgery under them under the age of 1. I've gone through the Botox phase, not worked, and I'm not convinced that operating on them by the age of 2 has any advantage over the age of 5, apart from the cosmetic and the pen pressure to straighten their child's eye and make them cosmetically look better. Thank you very much.